like a shadow.
Yeah.
So I'll say hi again. I'm Sue. Pleased to meet you.
Nice to meet you too.
And you must be pleased that you're coming to the end of your training.
Sure.
So today we're going to do a training session on Epistaxis.
Sure.
I thought that might be a good one to do, seeing that you are working in emergency. I don't know if you've seen any Epistaxis at all recently, or seen them, how they treat it and how they manage Epistaxis. Have you seen a lot of it while you've been doing your training?
No,
No.
I haven't.
So just so you know, we did some training sessions in here earlier today, and so we've covered our workplace health and safety checks that we have to do each time we start a training session, make sure everything's in order in the room. So we introduced ourselves just a little earlier before the camera wasn't working, so welcome again. I thought we would discuss Epistaxis management. So most of the nosebleeds that present to emergency departments are fairly minor. They look terrible, but they're actually what we call anterior bleeds. So they're usually coming from small vessels close to the septum, and so they bleed a lot, but they're not that dangerous. You can actually stop the bleeding quite easily. It's the posterior bleeds that are the ones that are a bit more nasty, because they're from arteries at the back of the person's nose, and so they can bleed a lot. And those are often the ones that you don't see early enough, because people have been swallowing the blood from behind and not pouring out of their nose so much, and so you can actually see them quite late. So you can actually still, in this day and age, die from Epistaxis. There's not many conditions in this day and age, from conditions that people have had over centuries, that you can still die of today. Pneumonia is one of them. Epistaxis. Post-tonsillectomy bleeds is another one. That's why they always keep them in cities and so on, close to where they've had their surgery in case they have a secondary hemorrhage. Epistaxis fits into that same category. So a person can actually insanguinate and bleed to death from an epistaxis if not treated properly. So even in the WEC, if someone's got a really big bleed that they're finding difficult to manage, they will transfer them to the Royal so that a proper ENT team can manage them, because if you don't manage it properly, your patient can actually die. So today we're just going to go through what a few of those causes might be, and then how, as a nurse, you can assist the doctor in managing the epistaxis. So what do you think would be some of the reasons that a person might develop a nosebleed?
Trauma.
Yeah?
Yeah.
What else? Trauma like what?
Like hit to the face and stuff.
Yeah?
Yeah.
Yeah. Anything else? What's the most what do you think is the most common cause for an anterior small bleed, but that won't stop bleeding, that brings people to emergency departments? So yes, you're quite right, sport injuries and that, when people get thumped in the nose, yes. But what do you think the most common is?
When they sneeze, if they sneeze too hard.
If they sneeze too hard?
Yeah. Yeah.
Picking their nose
Picking the
is, so people go, I don't pick my nose. Everybody at some stage, without even realizing it, might just find something a bit irritating. A lot of people do. It's just one of those things. They might be a bit embarrassed when they get to an emergency department to say that that's what they did, but it is just one of those facts. It isn't actually the most common cause of a nosebleed is somebody fiddling with their nose. Instead of giving it a blow, and then on the other hand, some blow too hard and can actually cause a bleed. So those are the most common ones. For children, what do you think is the most common reason for nosebleeds?
Same thing if they play with their nose. And
That
then
as well, and what
they
else?
can put something
Yes,
like
they
foreign
put,
body.
yeah, they usually put like little beads or
Yeah.
in little objects or toys and that they've been playing
Yeah.
with. Especially 2-year-olds, that sort of age group, they like to experiment.
Yeah.
And so then they start putting things up their nose, in their ears. They have to say, oh, I wonder what will happen. And then, you know, the next thing, they can't get it out and it's stuck up there.
Yeah.
So that's, for children, it's usually foreign bodies that have caused, and they often then don't tell anybody because they think they're going to get into trouble. So they leave, and while they can still breathe and eat and swallow, they actually don't say anything until it's caused a bit of erosion on the side of the septum and starts bleeding, and then of course they come in. So sometimes that foreign object could have been up there for a while too. And then from a medical point of view, who do you think's susceptible to nosebleeds? So your patients that are in the hospital, if you're treating somebody for other conditions, what do you think would make them susceptible to nosebleeds?
Like on anticoagulant.
Yeah.
Yeah.
So your cardiac patients, your patients who have AF, who are usually on some type of warfarin or anticoagulant, so their blood's thin, doesn't take much, then just a sneeze or a cough or anything can actually start a bleed, and they find it difficult to stop it then because they're on an anticoagulant. So it's always good just to find out the patient's history and make sure that it's not just what you think it is, that you know their medical history definitely plays a part in that. And then there's also antiplatelet medication as well that can also cause their blood to be a bit thin. People with septal deviations, they also often have a few problems with epistaxis, only because they're getting more pressure on the one side, in the one near more than the other, because their septum is not sitting in the middle, and that can cause a bit of abnormal pressure there, and they can develop bleeds. And then of course the trauma ones, which we see the most of, other than non-traumatic stuff, is usually an elbow in rugby, or someone's got a hockey stick to their nose. Hockey's the favourite one, of the come with the hockey stick by mistake and whack them in the face. So our initial management, which is the same as management that you would do outside of a hospital setting, is to try and stop the bleed by using like an ice pack of some kind. So in the hospital we have proper ice packs, but at home you could use just ice in a bag, or some frozen peas out of a bag. Just make sure if you are using actual ice cubes, though, that you wrap it in something, because ice actually burns, and so you'll cause like trauma to their skin. So you need to put like a daily or something over the top, or a tissue or something, before you put the ice on. These packs are okay because they're obviously covered. So these are the ones that we've got in the WEC. I don't know if you've used them at all. Do you use them on ankles or anything like that?
I've seen them, I haven't.
You haven't used them. So they come there's crystals in there. I don't know if you can hear the crystals in there. So once you give it a good squeeze like that, by giving it a sudden movement, that's what sets the reaction off inside there, and then that will set it off to actually start making it cold. So, and then once it's molded and it's become this firm blob in there, you can then actually mold this into shape. So those crystals haven't quite crystallized, but if I went like that and actually set them off, then once it's made a smooth, you feel that some of them are starting to go hard. If you feel there, it's starting to go hard. Once it's a solid hard patch, then you can actually mold this whole packet so that you can put it on. Otherwise you can use ice blocks in a packet, and just make sure that you cover it properly. These can only be used once those crystals have worked. This packet might be a bit old, so it might not actually crystallise, because this is our demo one. Then it just becomes like a solid pack. So, and then for them to pinch their nose. Now, a lot of people get that also a little bit wrong. You find people pinching their nose up here, Well, yeah. So up here is not the right spot
That's right.
because you're sitting with your bone here, so
Yeah.
you're actually not pinching anything. So that's quite correct what you were
Yeah.
doing. At the end of where the nasal septum, where it splits there, and you get the soft tissue on the side, on the lateral side like that, that's where you press. So there.
And
And
go
up like,
upwards.
yeah. So that's the way that you do it, like that. But you see people pressing up here.
That doesn't work.
No, because you're pressing onto bone. So you need to say, no, you got your fingers up too high, you need to bring your fingers down. If they're still actively bleeding, we ask them to tilt their head like that just because otherwise it's very tiring. But we don't like them to lean too far back because the blood drains to the back then and then they swallow it. And then you can't actually see how much they're losing either and whether it's stopped or not because then it's going the other way. So we actually like them to stay forward so we can see if blood's still coming out of their nostrils and not into the back
Not
of their
too
throat
far,
and they're
yeah.
swallowing. But you can't hold like this. It gets very tiring to be leaning forward. It's easier for the person to be up like that a little bit. So we, even in the hospital, that's still our first line of treatment and we try that first. So say that hasn't worked, then obviously the doctor is going to start their management. So have you seen them use any devices to stop an epistaxis? No?
No, I
Okay.
haven't.
Do you know what they use? Can you think what they might use to stop a bleed if that hasn't worked?
Gauze, or like the only other thing I can think of is like a tampon. I don't
Yeah.
know if you use those, but
Yes.
I know
Yeah.
like first aid sometimes they use those. And they don't
Yeah,
have
well,
anything
that's
else.
exactly what we use. So we actually use the Rapid Rhino, which is quite a fancy tamponade. It's basically to tamponade the bleed, but you get a whole lot of different types. Miracell nasal catheters are ones that they use as well, or even just tiny little catheters. So that you can actually, that's the instruction that you can follow as I'm talking about it. I'll give you a copy as well. You can both see one. So that's what the Rapid Rhino looks like. This is the packet that I've got, that's there, over there. And so when you take it out, it's got that blue casing on the outside. That's just to support the so you soak it just for a short while. So when it comes out of the packet, you can feel it's like really soft on the silky on the outside, and then that's the firm tampon in the inside that's going to get softer when it swells up now with the water. So that feels quite hard still. Yeah. So that's what it looks like. So they just soak it in like a kidney dish for a while, and then they feed it in onto the floor of the nose. So as they're going in onto the floor like that, and then now they're going to expand it. So you don't want, that's only so that it slides in easier, because the blood's going to soak in onto that tampon and expand the tampon itself. But to keep this inflated, which is also then putting pressure on the side of the nostril, is they then push air into it. So they use a 20 ml syringe, and then they inflate it. So remember, you only inflate this with air. This isn't to be inflated with, and you actually only soak this in water, not in saline. Saline destroys the outside of the covering, this covering. So you just soak it in a little bit of water just to wet it before. Yeah, just in sterile water, just like ordinary sterile water. Then you put it in a dish. It doesn't have to be sterile water, it can be clean water because your nose isn't sterile. But usually when you're working, you get a sterile of water, and you just put it into the kidney dish. They just soak it like that just to wet it a bit. They put it in onto the floor of the nose, and then once it's in, they must go past in, make sure that they are past that point, because otherwise it's not in far enough. And then they use a syringe, and you can have a feel with this if you like, that they then blow it up until that is firm.
And tight.
Yeah, firm and tight, but yet still that it's, otherwise you don't want to inflate that too much, otherwise it's going to burst.
Okay.
So you can see I've sucked all the air out of it now, so it's flat.
So when we take the air out.
Yeah, when you're going to remove it.
Yeah.
So for putting in, then you just put in like so, and until you can feel that it's firm,
Yeah.
because that's in the nose already, so just feel that that's firm. So it can take up to about 20 mils actually, that even though, because it's going there and into there as well. So that's why we give them, the docs, a 20 mil syringe. They must probably use about 15 or so of the 20 mils to make that nice and firm. And then you take this onto the side of their face. So if this is in their nose like this now, then this piece hanging here, you just tape onto the side like so, and you let that do its thing. So it's going to absorb the blood from the bleed, but at the same time it's putting pressure on where the bleed is, and hopefully that will stop the bleeding. If the patient then, after, like, you bring them back tomorrow after seeing them today and they go, I haven't been swallowing any blood or anything, then we can take it out. And then to take it out, you must first remove that air. Otherwise you're sitting now with a very heavy tampon because it's full of blood, and to pull that out is very uncomfortable. So it will never go completely flat because obviously it's got fluid in it, but the air that you had put in surrounding it to make the pressure, you need to remove that.
Yeah.
So you remove it until it's completely flat, and this is a one-way valve, so it's completely flat now. And then
Easy to come out.
and you can feel now the air was in there, now
Yeah.
the air's not in there now. See, it's gone flat again. So obviously it would still be a bit more soaked, but it's flat.
Yeah.
And then you take it out, and hopefully that works. Not everywhere has these, what they call these are called rapid rhinos. Some people just have, I've got a little one. They look like that, but more just a flat, actually I might have a picture of it. Oh, it looks like that. There you go. That's what it looks like. Just flat packing like that. So it looks the same as this, except it's just a flat piece like this, and it's got a tape on the end. Now not all of them come with tape either. Some of them only have a just the tamponade and no tape, not these black pieces of tape here. If that's the case, you need to put tape on it yourself, those tags. And so the way you do that is to use suture material. So you get some suture material, because that won't snap off, because it's nylon, and make your own tags onto the end of it then, if it hasn't got those black ties. And the reason why it wouldn't have is because they would have got the cheaper brand that hasn't got the ties on it, because it's more expensive. And so not everywhere. So just be mindful that when you're doing this, that you've got a needle at the end. You just cut that off, and you use your nylon suture that you just, once you've put this through, like so, basically like sewing, you make your knot, and you've got this, you make two ties at the end, the same as what's in the picture there, so that you've got something once you've put it in as your ties at the end. Otherwise this can travel up and lodge in, and then you'll have a foreign body in the nose that you can't get out. Add a secondary problem to the initial problem.
That's right.
Shots got that. So if they don't have a rapid rhino and they just have the plain tamponade like that, it will come with those black pieces of tape on it. So those ones you do need to keep in place. And you see that tie there that's at the back?
Yeah.
So once that's in, because it's not applying pressure the same as this is with the air, you need to keep it in there, otherwise it's just going to fall out. So the way you do that is you bolster it up in the front. So you can actually buy bolsters, Otherwise, you can just roll up some gauze and make a round plug, and then tape or more like a roll of gauze over it and around like that to hold it in. Otherwise, every time they move, it's just going to fall out.
Yeah.
Where with the rapid rhino, and that's why we use that, it's got the air that's actually keeping it in. Where the plain ones, just the nasal packing doesn't have that, and so the weight it would just fall out, and so that's how you need to tie it in place. It's putting it in. We'll show you. Yeah, so you see you need to use something where you've got a bolster of some kind.
Yeah.
Either make your own or they come like that. That you put it under the nose like so and around and tie it at the back. And then that's the way that you manage the epistaxis. So it's not really high-tech stuff. It's pretty basic. But it is important to know, especially with the rapid rhino, about the air, because people forget to take the air out when they want to, and so that is really important. And then the aftercare for your patient that has whichever device they have in, if they are swallowing a lot, they need to come back, because that just means that the blood's now moving in the opposite direction.
Yeah.
Just because it's not coming out the front doesn't mean to say that the bleeding stopped then. If they keep on coughing it up or feel that they're swallowing it, then their bleeding hasn't stopped. Then we need to repack them, or even put it maybe higher up, or maybe it needs to be cauterized. So we need to make sure that we give those instructions to the patient. And just because they're not bleeding out of their nostrils doesn't mean to say that the bleeding stopped. So it's very important to give that information to the patients, because otherwise they wouldn't know that. They would just swallow a lot and in fact still be bleeding. So that's how we manage epistaxis. So we're very fortunate in that we use the rapid rhino 90% of the time, but they do come at a bit of a cost. So when you guys are out working at various other locations, you may not always find these. You might just find the plain packing ones with, most of them though, they do come with those black ties on there already, which you also then need to tape onto the side of their face and then put your bolster over the top. So do you have any questions?
No.
You sure?
Yeah.
Yeah?
Thank you.
That's all right. Did you learn something today?
Yeah, it's simple but important.
Yeah. Good practice wherever you are to know. And this a rapid rhino is a universal practice. So each organisation might do something slightly differently, but basically the way that you're going to pack the nose is the same. So if you know the principles of it and why you're doing it, then you can use that in your practice wherever you are. So yeah. So thank you very much. Just stay there for a minute and I'll come and see you in a couple of minutes.
Sure.
Basically, they're just tampons.
Yeah. 1 cent.